I'm Ilan Kedan, a clinical cardiologist from Cedars Sinai Hospital, Cedars Sinai Heart Institute in Los Angeles, California. I'm here following a recent presentation at the International Academy of Cardiology annual scientific sessions in 2017, which is held in Vancouver, British Columbia. I'm here to talk about the evidence-based use of handheld ultrasound for clinical cardiology. First, I would like to talk about the importance of physical examination and the reason why we actually examine patients. So the purpose is really to connect with our patients, make diagnoses, test our diagnoses, and assess the effect of our treatments on our patients. With the handheld ultrasound, we can identify all of these goals, and further, we can better diagnose, treat, and prognose our patients with the data that we can acquire at the point of care with handheld ultrasound. And there are data to support that. So point of care helps us clarify the actual actionable data at the point of care. It essentially provides us with decision support that's superior to physical examination and allows us to better understand how we can treat our patients most precisely. We can assess the diagnosis of patients with a great degree of accuracy compared with the conventional larger ultrasound machines, and also a negative predictive value or a normal finding with handheld ultrasound is a very powerful tool in eliminating high-risk disease. With respect to prognosis, the prognostic information we can acquire at the point of care, including our study, which we found the diameter of the inferior vena cava before and after cardioversion did prognosticate the likelihood of recurrence of atrial fibrillation in patients. So in other words, patients who had larger inferior vena cavas before cardioversion and after cardioversion were more likely to revert to or go back into atrial fibrillation after cardioversion at 30 days and 90 days post-cardioversion. Also, there's very valuable prognostic information in patients with cardiac arrest and pulseless electrical activity. Patients with essentially cardiac standstill, as identified with handheld ultrasound, have a very, very poor prognosis or do not live, have a 0% chance of surviving to leave the emergency department. With respect to management of patients, serial imaging over time in heart failure patients, in our cohort of patients, high-risk heart failure patients, in the setting of a multidisciplinary pharmacist-run clinic, these patients were better informed and had lower heart failure hospitalizations and total hospitalizations and hospital utilization at 6 months and 1 year post-enrollment in our program with the use of handheld ultrasound. So in summary, the use of handheld ultrasound is an emerging technology, and there is evidence to support it in favor of its daily use in clinical cardiology.